right, so thank you. The title of the talk today is Improving Communication in Primary Care Visits for People with Communication Disabilities. All right. And I just want to first give a shout out to PCORI, the Patient-Centered Outcomes Research Institute, who funded this research, and also the disclaimer that the views presented in the presentation are solely the responsibility of the authors and do not represent the views of PCORI. All right, so I want to just first start off with definitions. So I said we're going to be talking about communication disabilities. So a communication disability is really any disability that affects how a person communicates. It could be hearing, speaking, understanding, or expressing language, or writing or understanding written language. And population estimates puts it at about 14% of the US adult population lives with a communication disability. And I want to give some examples. So hearing, it could be individuals who are deaf or those who have hearing loss. So either congenital, age-related, or other. For speech disabilities, it could include people with dysarthria due to conditions such as cerebral palsy, stroke, or ALS. Could also include people who stutter or those who have apraxia, for, again, could be related to various conditions such as autism or traumatic brain injury. Additionally, we have language disabilities, which, again, here are a few examples: aphasia, which can be caused by a stroke, or a developmental disability. And then lastly, we have a voice disability, such as aphonia, due to conditions such as a laryngectomy or also spasmodic dysphonia. So research that colleagues and I have done have demonstrated that folks with communication-related disabilities have worse health and healthcare outcomes. And this is a graph displaying major chronic conditions. So we have hypertension, cardiovascular, stroke, emphysema, asthma, cancer, diabetes, arthritis. And you will see on the very left-hand side in blue is those with no communication disability. And then next we have those with voice only. Then we have speech language disability. And then we have speech language plus voice disability. And you can see it really across all of these conditions that those with communication disabilities have higher rates of these chronic conditions. And this is all statistically significant except for speech language and cancer disabilities. Those with communication-related disabilities, in a national survey, they were asked to rate their quality of health. And you can see on the left-hand side is those with no communication disabilities. And then again, we have voice only, speech language, and speech language plus voice. And you can see the light blue, which is at the very bottom, is fair or poor health. So those with speech, language, and voice disability, almost 50% of them report having fair or poor quality of health as compared to those with no communication disabilities being 11%. Then next, looking at access to healthcare, those with communication disabilities actually report fairly high levels of having a usual source of care when they're ill or for routine care. But if you look on the very right-hand side of difficulty finding a provider, and this will come up later, is that those with communication-related disabilities do have difficulty finding a provider who's willing to see them. So those with, again, speech language or voice disability, it's almost 10% compared to those without a disability, it's 2.5%. And then this next graph looks at unmet needs for healthcare. And so again, those with communication-related disabilities had higher rates of reporting that they delayed medical care or they forgot went medical care due to cost and also availability. So, and then finally, we see that people with communication-related disabilities also have higher rates of healthcare utilization. So higher rates of emergency care department use, higher rates of inpatient stays, and they're 3 times more likely to experience an adverse medical event when hospitalized. So when looking at, what is leading to poor quality of health and healthcare outcomes, patients with communication disabilities report that one of the main factors that impacts the quality of their care and the quality of their health is poor patient-provider communication. And there have been numerous studies that have demonstrated that those with, again, patients with communication-related disabilities describe poor quality of care. They report being excluded from conversations or decisions about their care. They describe being talked down to, being patronized by their healthcare team. And then interviews with providers report that often they're unsure of how best to communicate with patients with communication-related disabilities. Fortunately, we do have evidence that there are effective communication strategies, and that when communication partners use these strategies, the quality of communication, both expression and reception, do improve. We conducted a study where we actually followed individuals with, in this study was aphasia, and we recorded their clinical encounters, and we found that providers inconsistently used these evidence-based communication strategies with patients with aphasia. And then when we went back and talked with the physicians, we asked them what communication strategies you should use with your specific patient. And they were really unable to identify the specific communication strategies to use with their patient. They could talk in generalities, but didn't know what strategy their patient needed or would benefit from. So this really led us to the aim of this study, which was to increase primary care providers' use of these evidence-based communication strategies for the purpose of, hoping to improve the quality of communication between patients with communication disabilities and their, again, primary care providers. So this led us to the INTERACT trial. We received funding from PCORI in mid-2020. So just want to pause there. We can all think about what we were doing in mid-2020 and which impacted everything, including the study. And the goal of the study was to implement and compare the effectiveness of 2 interventions across 4 healthcare systems. Okay. If you're familiar with PCORI does what is called comparative effectiveness research. So they fund research that takes 2 interventions and compares them to see which is more effective. In our case, we have intervention A, which is a training for healthcare team members. And then our intervention B was a patient-directed communication strategy tool, which I'll show you in a little bit. And what we were comparing is we gave all of our providers who participate in the study and the teams our intervention A, which is the training. And then we randomized clinics to start intervention B, which is our communication strategy tool. We did this study, again, we said 4 sites, but technically it was 5. So we did the study at the University of Illinois, Chicago, the Mayo Clinic, University of Colorado Health, so UC Health, and then Denver Health, which is here in Colorado, and then Michigan Medicine. So we had 2 clinics at UIC, 2 at Mayo, 2 at Michigan, and then 1 at UC Health and 1 at Denver Health. And I will point out that UIC and Denver Health, those are both safety net health systems. So we had 3 clinics that represented safety net health systems. So in our first aim, the goal was to refine our interventions. So we conducted focus groups and interviews with 46 people, including 26 individuals with communication disabilities. And we recruited individuals with a wide range of communication disabilities. And then we did talked with caregivers and also providers. And the goal was to refine this list of communication strategies, which was out there in the literature, define our educational content, and then also develop the tool format. So this is a lot here. I just want to quickly share. This is what we landed on for our communication strategies. So we identified on the left-hand side, you'll see 16 different communication strategies. So the first one is look at me when either you, the provider, or I are talking. And then the rest of the strategies we broke up into two categories. First, when you, the provider, are talking. The first one is use words that are respectful and appropriate for my age, and it continues on. And then the next group of communication strategies is when I am talking, provide me extra time to think about what you said. And again, there's 4 more strategies after that. We also came up with a list of, with our, again, participants, list of accommodations that folks might be using that they wanted to alert their provider. And I'll say that the list of these strategies has been recently published in a publication, which we can share at the end of the PowerPoint. So our education, the content of our education, we included definitions of communication disabilities and disabilities. We quickly reviewed evidence on disparities. We did an overview of what language to use and not to use when talking with folks with disabilities. Then we reviewed those 16 strategies as well as the accommodations that we identified. The training we developed was about 25 minutes long. We developed an e-learning module and also a PowerPoint that we delivered virtually. And then we went through the process and had our education approved for continuing medical education credits. So providers who took the course could get credit for doing so. And then the tool, we developed an electronic and paper version of the tool. And I'm actually going to exit out of my PowerPoint and bring you the tool. So again, this is really small. We will make, at the end, we'll talk about how we're making this tool available. But you can see here, the first step here is asking folks if they're having a care partner who is at the visit with them. And that, so someone clicks yes, and then if the care partner is completing the tool for it. And you can see the little ear next to the words, and that you can click on and it can be read to you. And then first, the next section, it gives you what, communication difficulties you have. And then this next section is if you use a communication aid when communicating. So you go to next. Should go to next. There we go. And so this takes you to the list of the strategies. And so patients were instructed to pick 3 strategies that they wanted the provider to use with them. And so again, you have all the strategies here. And you would pick 3 strategies you would want. It can be, each of these can be read to you. And then for each of the strategies, we also have.
I want you to take 2 medications. The first one is thyroid.
So each strategy actually has a short video. These are, the 15 to 30-second videos explaining what that, demonstrating what that strategy is. We also use those videos in our education. We had both sort of kind of a good version, like an appropriate version of using that strategy, and then also the wrong one for folks to see. Okay, and then once you select the strategies, you can show what devices you're using, and then finally, this is the summary page of, these are the 3 strategies that the individual wants the provider to use, and this person is also indicating that they're using a whiteboard. Okay, I will actually pause there and see if there's any questions about the tool. All right. Back to our. All right, so again, we did a trial. So we did this again in 8 primary care clinics, and we collected data between January of 2022 and also through July of last year. And we did our study design was called a stepped wedge study design. And what that means was that each of the 8 clinics were randomized into when they would start using the tool. So all of our 8 clinics ended up using the tool. It was just a matter of when they started using the tool. So you can see here in this graph, everyone, in month 1 received the education, and then the first clinic would start using the tool, and every 2 months, a new clinic would start using the tool. And I just point that out because we'll get to that when we talk about some of the results. All right, so our participants were all providers and staff at the participating clinics. And then our patients were any of the patients of the clinics who were 18 years and older. We recruited individuals with really all types of communication disabilities, speech, language, voice, and hearing. But we did not include those deaf patients who use sign language. We required an interpreter because that was, we did not want this tool to be a substitute for not getting an interpreter. So they need an interpreter. They were not part of this study. Okay. So in terms of how we recruited patients, our study team would, for the patients in each clinic, would review the upcoming scheduled appointments, and then review all the electronic health records of those patients. We had a series of keywords and also 300 ICD-10 codes that we identified that were related to communication-related disabilities. For those who we identified that they might have a communication disabilities, we called as many of them as we could to actually ask them if they had a communication disability, so screen them. And those who said, yes, I have a communication disabilities, they were asked if they were interested in participating. And if they said yes, we would ask them to arrive at their next scheduled appointment 30 minutes early to go through our consent form and then conduct a baseline survey. If the patient was in a clinic that was currently using we say A plus B, so the study arm, which was using the tool, the patient was given the tool to complete in the waiting room prior to going into the visit. And again, we had an electronic version. We also had a paper version that if for whatever reason they didn't want to use the electronic version, they could use the paper version. And then after the visit, the patient completed a survey, both immediately after the visit, but then also another survey 7 days later. So the outcomes we'll be talking about today were the patient survey. So that immediate and 1 week later, we asked about satisfaction and then global health questions. And then I'll also be presenting data from our qualitative interviews with our providers and staff, as well as our patients. All right, now I am launching into the results. So the first thing I want to go through is talking about our demographics of our participants. So first, I'm going to draw your attention to we had 687 unique individuals participate in the study. We had, because of the length of the study, participants could participate again, and we did have another almost 100 participants participate a second time, but we didn't want to count their demographics twice. So right now we're just presenting the demographics of everyone who participated at least once. Okay, so, and then you can see across our different sites, we have, these are our 4 different sites. We have variation in kind of how many people participate. And then also I want to point out this first column here is those in intervention A and those in intervention A plus B, which is different across the different clinics because again, they were randomized at different points to start. I want to draw your attention to, again, going through some of our demographics. So our race and ethnicity. This is looking at statistically significance. It is different. So what means that even though we randomize folks, randomize clinics as to when they would start the intervention, and we try to have balance of our demographics, we did have a difference. So in our intervention A, we had more individuals who identified as white, with 57% as compared to 49% of our intervention A plus B. So using the tool. And this will come up later. I'll revisit this. This is now looking at their age, this first one. So we've collapsed some of their age groups. And you can see that actually looking at our average age between the two arms, it was about 63 years of age. And that was, again, across both arms. And then we do our education. We did have a range of education. So 23 or about a quarter of our participants in both arms had either a high school diploma or less education than that. 30, about a third had some college or an associate's degree. And then a little bit more than a third had a bachelor's degree, master's, or kind of more advanced degree. So we did have people with a range of educational backgrounds. This is looking at the first one. This is a lot here. So the first one is employment. And again, just to draw your attention to this top here. So in our intervention A, 29% were working either full-time or part-time compared to 23.8% in our intervention B. We had similar, about 20% were not employed or not able to work. And then about half of our participants were retired across both arms. In looking at marital status, 56% in arm A were married compared to 50% in our second arm. And then we had living alone about 20%. Living with others, about 77% lived with others in our intervention A, and then intervention A plus B, about 70%. And then our last question was how hard it was to pay for the basics in the last month. So a social determinants of health question. We had about a third, not quite a third, saying that it was somewhat hard or very hard to pay for the basics in the last 3 months. Our next, we had this first one is caregivers present in the clinical encounter. We had about 26% in intervention A said yes, caregiver was present versus 21% in intervention A plus B. And then here, I want to draw your attention to what is the length of relationship with the provider you saw today. So this was statistically significant across our both arms. So in our first arm, we had 18% said this was a first visit or they had known the provider for less than a year. And this is compared to 27% in our intervention A plus B. And then going down, if this was, a relationship of 3 or more years, 68% in our intervention A versus 57% in our intervention A plus B. And again, that's going to come up later. And so really just to summarize a lot of these demographics is our intervention A plus B were folks that had a new relationship with their provider, were more likely to be identified as non-white or or Hispanic or Latino. And they also had less education. Then type of communication disability, this is their primary diagnosis. You could see where about 2/3 had a hearing disability, and then but we had those with stroke or neurogenic communication disability, so like MS or ALS. About 10 to 7%, 7 to 10% had a dementia. About 6% in both arms had a developmental disability. We had 4% with seizure, about 4% voice disability, and then we had, yeah. Okay. So this is launching into, so that's our demographics, who we recruited. Now we're launching into our results. So again, we asked it's called a promise. It's a validated measure asking about people's general sense of their health. And so we asked about physical health and mental health. We also had asked about self-efficacy. And so what we can see here is we didn't, looking at our statistical significance here on the right, we did not see a statistical significance between A versus A plus B. So the intervention did not change patients' report of their physical or mental health levels or change their self-efficacy. And self-efficacy is their feelings of their ability to manage their health conditions. Okay, so next we're going to move on to our communication scores. And so we used a tool called the communication assessment tool. And this has 15 different items. And this is, I'm going to go through some of these items. And what I will say is that for the most part, so this first column here is our unadjusted odds ratio. So an unadjusted odds ratio, or unadjusted really generally means that we're not taking into account other demographic characteristics of the participants. We're just looking, did group A versus A plus B, were they different from each other? In the second column is our adjusted odds ratio. And what this is looking at is, and you can see there on the very right-hand side, we looked at taking into account the participant's age, their gender, the length of relationship with their provider, the presence of a caregiver, and then also a communication disability. And so we said, okay, if we took all of those things into account, what is our adjusted odds ratio? And an odds ratio is, what that means is that it is the likelihood that it is different. So improved. So if it is a 1, like a 1.0, that means the groups are exactly the same, okay? This first one, this one here that I have highlighted in red, this is the item treated me with respect. It's the odds ratio is 1.71. That means that those in the intervention A plus B had a 70% odds of reporting a better score for that item compared to those who are just in the A arm. And then what's in parentheses there is what is called our confidence interval. And our confidence interval is to say we're confident that even though 1.7 is the number we came up with, it could go up or down a little bit in our odds ratio, but we're 95% confident it's between 1.01 and 2.91. Okay. So what you can see just looking down all of these, that all of them have a positive odds ratio, except for encourage me to ask questions, which means that, again, our A plus B group did better. And you can see that in our adjusted odds ratio to taking account those demographics. Again, it's all positive. But if you look at our confidence intervals, they're wide. And so if it includes one in the confidence interval, then technically it means that we are not confident that it is statistically significant. The one item that did reach statistical significance is, again, this item treated me with respect. So to summarize that, so patients who use the tool were more likely to report that their provider, kind of in a scale of 1 to 5, reported excellent with treated me with respect. Okay. The other items, just to give examples, there was an item about showed interest in my main health concern, paid attention to me, let me talk without interruptions, gave me as much information as I wanted, talked in terms I could understand, etc. Okay. But given that all of them are skewing positive, it did make us want to look at again, maybe that there are certain patients that are doing better than other patients. And so again, that our adjusted odds ratio does take that into account. But what you'll notice in that adjusted odds ratio, we don't have race and ethnicity as a covariate. And the reason why is has to relate to our study design. Remember that we randomized people of like the clinics into when they would start the intervention. And it just happened that some of our clinics had more or less white people and non-white people. So for example, we had 2 clinics at the Mayo Clinic. Mayo Clinic, Southeast Minnesota, is fairly white. And so whereas some of our other clinics, UIC is located in, the heart of Chicago, we had a much higher rate of people identified as non-white or Hispanic or Latino. And so because of that, kind of differentiation between our clinics, we ended up having some of our cells having 0 persons who are who identify of color in our intervention A plus B. So, but what we have started to do, and we're still in the process of doing this, is what is called a subgroup analysis. And so this is what we did was we just did unadjusted here. And what we did was we just looked at those in the left-hand column who reported being kind of other race or ethnicity other than white, non-Hispanic. So they're on the left-hand side. And then folks on the right-hand side are those who identified as white or non-Hispanic. And you can see that, again, the 2 I have at top, so greeted me in the way that made me feel comfortable and treated me with respect, remain significant for those who, again, are other, but it was not significant for those who are white or non-Hispanic. And if and so you can see it also increased the odds ratio. So treated me with respect, that those who are kind of other race and ethnicity, again, other than white, were 2.15 times more likely to report this excellent for this item, treating me with respect. And I put an asterisk across all the items as we go down that were, there was a greater odds ratio for our, again, non-white, not Hispanic. And I see Alicia has her hand raised. So
yeah, just real quick. This is a ambulatory outpatient setting?
correct, primary care.
Just want to be clear. I'm just like thinking through on the inpatient setting, and I know if anybody's from a hospital, you do the H caps and stuff like that. And what I'm starting to look at is some of the questions related to nursing communication as well, communication about medications, and then like discharge instructions, don't seem to be doing that well. And we're just starting to stratify our findings in HCAPS too. So,
Yeah.
I mean, I'm definitely noticing that in that kind of communication is there's definitely some room for improvement, but I think that's on the inpatient side. But this is good to look at.
Yeah, absolutely. Thanks, Alicia. Yeah, this was all outpatient. And one thing we didn't do is, again, all of our participants had communication disabilities. We were not interested in, or we didn't collect data on those who had no communication disabilities. So we didn't have a comparison of the two to demonstrate that difference. It was more of how do we, intervene and help improve kind of where folks with communication disabilities are at. But I think one of the things you point out is one of the challenges of doing research in this area is, we were not recruiting, for example, folks who all had diabetes. And so you could look at their, A1C outcomes. They were coming to the doctor for all sorts of reasons. So we had to ask these sort of more kind of experience with care questions that they were relevant across folks. Okay. This is data from just using the tool. So those who use the tool, we asked them about their experiences using the tool. So you can see there we asked, did the provider use the strategies you selected on the tool? And 86% of people said yes. About 13% said either no, or I'm not sure if they actually use those strategies. And then we asked just about how easy the tool was. And so the first question, how easy was to use the tool? 91% said it was super, it was easy to use. 88% agreed or strongly agreed that most people would learn how to use the tool easily. And the next question, everything in the tool was easy to understand. We also, again, 88.6% agreed or strongly agreed. And then the amount of information provided in the tool was too little was 4%, just right was 93%, or too much was 1.6%. So we felt pretty good about our tool of kind of where we landed, that people thought it was easy to use and liked using it. So again, we did interviews with 38 folks who used the tool, patients who used the tool, and they, again, across the board said the tool was easy to use. They thought maybe the paper version might be useful for older folks, but people did also like the videos on the tool. One interesting thing that really came out, and I think it's an interesting discussion point, is we just didn't quite expect this, is that patients expressed to us that they were nervous about using the tool and that it would convey to their provider that the patient didn't think that the provider was doing a good job. And so they were nervous about honestly advocating for themselves. And if we go back to that at the beginning, showing the data that folks with communication disabilities have a much more difficult time finding a provider who's willing to see them. You can imagine that they're going to be nervous about, they finally found a provider who's willing to see them, of not wanting to again, offend the provider. They, again, across the board said the tool was more useful if it was, or using the tool if it was established relationships, if they knew the provider for a long time, that the provider was often already using the strategies, so the tool is less helpful. But if it was, again, new to the patient, or that the provider and the patient were new, the tool was much more helpful. And so one of the things we're going back and doing with our data is actually going to do that kind of subgroup analysis to see if, again, the communication was better for those who, or like was more improved with the tool in those who had a less established relationship. And patients said that, again, kind of universally said that they would want to use the tool in future visits, including in other clinic settings, like an inpatient or emergency room, or with different, specialty care providers. In thinking about the future, they really endorsed wanting the tool to be a part of their electronic health record. And that, so anyone, staff or provider opening their chart would see that, these are their communication strategies that they want. And they liked completing the tool in the waiting room, but said they would be also willing to do it at home. And then we have interviewed 16 providers who participated in the study. Again, they also said the tool is more helpful for new patients. They also said that those with non-hearing communication disabilities, they thought this was more useful. The strategies they said were not rocket science. None of these were new, but some of them were surprised that some of their patients that are like, I didn't even realize that they had trouble communicating with me. I didn't realize they had a language processing disability or their hearing disability. And some of them were also surprised by what strategies their patients wanted. So again, the tool was really helpful in alerting them that one, the patient had a communication disability, and that they what strategies the patient wanted. They were all interested in continuing to use. They strongly said they would like to continue to use it, and all would recommend it to their colleagues. So some of our successes and challenges, COVID threw a huge wrench. A lot of our visits were moved to telehealth, and we weren't really set up to provide this intervention in telehealth. We did, not just our study, but many studies have seen a decreased willingness to participate, both patients, but a lot of it with the providers, just because they're so overwhelmed. And then we'd have things like we'd have to stop recruiting for like a month because one of our, study staff tested positive, and so they would have to, quarantine, and it'd take them a long time to get back to the clinic to recruit. So we just had all these kind of stops and starts with our recruitment. We did have trouble at the, we anticipated this, but it was true, difficulty identifying patients with communication disabilities and a disability definition. So we, some people would, in our screening process, would say, yes, I have difficulty communicating, but I don't identify as having a disability. And so we had to, kind of really modify our scripts of kind of recruiting patients to include both disability and difficulty with, to be more inclusive of folks. And then we found the tool was not always implemented the same way. Sometimes, again, the patient was supposed to bring the tool back with them into the visit and use that to start a conversation. But sometimes we found that the tool might have been left outside of the room, or they've, wouldn't show it to the provider. So again, there's some implementation pieces that we would need to work out. But overall, patients loved the study. They were thrilled to participate. They, really, over and over, people said, I am so excited that someone is paying attention to this. I haven't been able to talk about, and I didn't know how to talk to my provider about my communication disability. And I'm just so thrilled to be able to participate in a study about this topic. So in summary, the patients who use the tool were more likely to select the response excellent in response to the question items about providers treating them with respect. We didn't see a change in patients' reported quality of health. Patients and providers liked using the tool, wanted to continue using the tool. And it's likely more effective with certain populations, like new relationships or non-white patients, and then patients with less common communication disabilities. Future directions, we're looking at integrating it into the EHR. We want to think about evaluating it in other clinical settings, and also thinking about, can we expand this to other disabilities that, yes, we're focused on communication disabilities, but the thing we moved the most was feelings of respect. And we know that people with all types of disabilities struggle with feeling respected by their healthcare teams and their providers. So how could we expand this to be inclusive of other disabilities? We are going to be making the tool publicly available in the next several months on our website. We'll both have the electronic tool that people can use, that they could pull up on a phone or a tablet and use with their visits. We also will have a downloadable paper version. And I will just add, this was a massive team. We want to thank everyone, including our stakeholder advisory board. I know some of those members are here today. and also our participants. We absolutely could not have done this without our participants, and we are so appreciative of them. And then finally, PCORI for funding this work. And I will stop sharing and open it up for conversation and questions. Peggy, yes.
I have a quick comment. Tony and I obviously have a lot of interaction with people with hearing loss who are sort of ninjas at self-advocacy. And so the problem comes up with a provider who isn't able to implement the requested accommodations. There were a number of comments in the chat about how well done the tool is. There's a kind of elegance, and it made me think about the fact that it's easy to use and also might almost interject something like almost pleasurable in the provider's day. So I think that implementation is high on our list of things that we think about. And I give you a lot of credit for doing a super good job on that tool. Really terrific.
Well, thank you. I appreciate that. Other questions? So I see JR has a question about sort of the average time to complete the tool, and then for physicians to review the results. So we are still analyzing some of those findings. We have data in collected through the tool of the time and also what strategies people were selecting. We also we didn't present it here because we're still analyzing this. We did record a number of encounters, and we'll be looking at amount of time in the visit that that took. And yes, any thoughts on a maintenance survey? Yes, I definitely, because people, their preferences for communication strategies are going to change over time because of the type of visit it is, whether or not they have someone there with them. And so we do think that it would be something that could be implemented regularly. I think perhaps maybe again, once someone, if it was an EHR, someone has it completed and they have these are their strategies, that it could be a quick check at the beginning, when they check in and say, hey, these are your 3 strategies. Do you want to change these strategies? And so one of the things we've also talked about in the future version of the electronic tool, because we see sort of almost 2 audiences, like a healthcare team, or a health system could use this, but also a patient could have this downloaded on, on their phone, because they could, be on vacation and need to go to the doctor and use this. And so it gives them an option of, here are the strategies that they selected last time, and then they can go in and edit that. So yeah. Yes, Nancy.
I'm just curious, do you know who on the healthcare team saw the answers that the patient provided?
Yes, so it's generally the we were really aiming for the provider. So so when we asked them, did your provider use the strategies, and 85% said yes. So that is what we were kind of focused on, was that provider communication. We know, though, communication is really important with the entire healthcare team. Just for the sake of the study, we were focused on that relationship. But we do know, again, that others might have seen it. We're still, again, collecting data on some of that implementation of what ended up having, like who was handed it and all of those pieces. So again, something we would love to work out in a future project as well, of really kind of getting that implementation piece down. So Meg has a question is, do we think it needs to be filled out every visit? And I would actually turn it back to you all and say, what do you think? You know, how often do you think it should be completed?
I only raised the question because from my experience, people have said that they raise it and people sort of start to use maybe strategies and then basically forget about it and go on in their
Yeah.
normal way.
Yeah. Yeah. Yeah, and that's, one of the things we were, kind of wondering and hoping with the tool is that it would like be almost like this visual reminder of like, oh, hey, this person has a, communication disability, here are their strategies. But one thing though is that what happened was it was not, because nothing else happens. There's no workflow of a patient coming in and handing something to the provider. So it was introducing a new process in that encounter. And I don't think everyone was ready for that. And so that made things a little awkward. So I think, again, thinking about how we can integrate it better into existing workflow processes might have better uptake. Yeah, Bob.
Have you thought about doing a similar study with kids? I think it would be useful in terms of self-efficacy.
I think that's a great idea, and I think that is a future direction of yeah, with under 18, both as kind of younger, but also like transitioning to really help support folks as they transition, again, moving towards that kind of self-advocacy. But I will definitely say, again, this tool will be out there and available. We hope that you use it. But we're also open to like collaborations with anyone who is interested in using it with, again, different populations or expanding it. We love to yeah, kind of explore those topics. So question and Dira is appointment times. We have videos. We have about 85 videos. About half are without the tool and half with the tool. And we'll be actually comparing the time. So we don't have that yet. And so there are a few questions. So if you're interested in collaborating, so through the Disability Equity Collaborative website, and that's where the tool will be. We'll put it on that website, and we'll definitely, once it's posted, we'll send everyone out kind of an announcement and show you, exactly where on the website it will be. But yeah, you can contact us, Corey and I, through that, and we can discuss partnerships. I think there was a previous question about training, and there are, I would say, not a lot of trainings out there, but there are increasing number of trainings. I think the trainings have been good at demonstrating sort of pre-post knowledge. Now have trainings improved long-term behavior change? I think that is a little bit more challenging. But we do have under our healthcare resources some links to some trainings. We also, again, our training that we did, including all of our videos, we made 32 these little short, like again, very quick, 5 to 25 second videos that we are also happy to share with folks that you can use. And I will say that video, we have the patient, it was, we had actors, but the patient was an actor with a communication disability. And we'll get in the Corey's working on putting things in the link. Any other well, we're at the end of time. Again, happy to continue these conversations, hear your thoughts. We'll be again sort of announcing that when the tool is available. Excited to hear if you use it, how it went, and then we will be working on publishing the results and starting to kind of disseminate these findings. So, all right, thanks everyone, and yeah. Have a great rest of your day.